Welcome to Pharmacology Insights, where we break down complex pharmacology into simple, easy-to-understand concepts. For 50 years, ADHD pharmacotherapy has basically been a two neurotransmitter story: dopamine and norepinephrine. The drugs, amphetamines, methylphenidate, and atomoxetine, are different molecules, but with the same two targets: norepinephrine and dopamine. In July 2026, the FDA approved a drug that breaks that pattern. It's called Centanafadine, marketed under the brand name Simtriyo. It's the first ADHD medication built around three brain chemicals at once: norepinephrine, dopamine, and serotonin. In this video, we're going to cover how Centanafadine works, why the serotonin piece matters, and the question every clinician is asking: is this actually a step forward? Or just a new molecule doing an old job? Quick refresher: because the mechanism only makes sense once you understand the target. Your prefrontal cortex holds a goal in mind. Like a spotlight, shining on whatever you're supposed to be doing, even when other things compete for your attention. Two chemical messengers control that spotlight: norepinephrine and dopamine. Norepinephrine works like the spotlight's whole function. By binding onto postsynaptic alpha-2A receptors on dendritic spines, it strengthens the connections between neurons representing your current goal, locking the beam in place. Enough norepinephrine, and your attention stays put. Too little, and the spotlight drifts to whatever's shiniest in the room: a notification, a noise, or a random thought. Dopamine works like the spotlight's contrast dial. Via D1 receptors, it sharpens the difference between what's in the spotlight and what's in the shadows, making the important thing stand out and dimming the background noise. Too little dopamine, and everything looks equally interesting or equally boring. So, nothing holds your focus. In ADHD, both neurotransmitters run low. Not broken, just underpowered. The spotlight is dimmer and less steady than it should be. That's the entire logic behind every classic ADHD medication. Give the brain more norepinephrine and dopamine, and the spotlight gets stronger and holds still. But this isn't simply more is always better. It's an inverted U. Too little of either chemical, and the spotlight is weak. Push too far past the right level, and it gets worse again. Extra norepinephrine spills onto a different receptor that does the opposite job, blurring the picture instead of sharpening it. That's part of why acute stress, which floods the brain with norepinephrine, wrecks focus rather than helping it. Every stimulant and non-stimulant on the market is chasing that same narrow window. Enough to sharpen, not so much that it backfires. Now, where does serotonin come in? It isn't part of that alpha-2A, D1 attention circuit at all. It runs a separate pathway. The limbic system, centered on the amygdala, the brain's alarm center. If norepinephrine and dopamine run the attention spotlight, serotonin is more like an emotional thermostat. When serotonin activity is running low, that thermostat gets touchy. Small frustrations trigger bigger reactions, patience runs thinner, and mood swings more easily. Think of the difference this way. Norepinephrine and dopamine problems look like: I got distracted mid-task. Serotonergic-linked problems look like: I overreacted, snapped at someone, or I couldn't calm down after being upset. Clinicians increasingly see this kind of emotional dysregulation as a huge part of the ADHD experience. especially in adults. And it's never been what the previous medications were built to target. That's the therapeutic gap centanafadine is trying to fill, by acting on all three systems at once. And it's worth keeping this picture in mind, because it maps directly onto the pharmacology we're about to cover. A spotlight strengthener that also, for the first time, comes with a thermostat adjustment built in. Centanafadine is a small molecule, structurally unrelated to amphetamine or methylphenidate. Pharmacologically, it's classified as a norepinephrine, dopamine, serotonin reuptake inhibitor, NDSRI for short, and comes as a once-daily, extended-release capsule. It's approved for ADHD in adults, and in children and adolescents 6 years and older. Here's how it works. Normally, once norepinephrine, dopamine, or serotonin is released into the synaptic cleft and does its job on postsynaptic receptors, it gets swept back into the neuron that released it by dedicated transporter proteins. The norepinephrine transporter, or NET, the dopamine transporter, DAT, and the serotonin transporter, SERT. Centanafadine binds all three of these transporters and blocks that reuptake. It doesn't force extra neurotransmitter out of storage the way amphetamine does. It simply stops the clearance of monoamine that's already been released through normal neuronal firing. The result is more norepinephrine, dopamine, and serotonin lingering in the synapse, with more time to act on their postsynaptic receptors. Centanafadine doesn't hit all three transporters with equal strength. Preclinical binding data show it's strongest at NET, next at DAT, and weakest, though still clinically meaningful, at SERT. That weighting is thought to produce drug that improves ADHD symptoms, mainly through norepinephrine and dopamine, while also touching mood and emotional regulation through its smaller serotonin effect. And it acts fast. Adult trials showed statistically significant symptom improvement within the first week, and sustained through the 6-week study. So, where does this sit? Next to what's already out there. Stimulants like methylphenidate and amphetamines are the strongest and fastest acting option. But amphetamines specifically also push dopamine and norepinephrine out into the synapse rather than just blocking reuptake, which is a big part of why they carry higher abuse potential and Schedule II control. Atomoxetine, the main existing non-stimulant, uses the same reuptake blocking approach as centanafadine, but its target is narrower, mainly norepinephrine, and typically takes weeks to show benefit. Centanafadine is the first ADHD drug to block reuptake of all three monoamines at once: norepinephrine, dopamine, and serotonin, with benefits showing within the first week, faster than atomoxetine usually manages. That combination, the broader neurotransmitter coverage, reuptake-only mechanism, and fast onset is what first-in-class NDSRI means. And it's the genuine departure from the 60-year of dopamine norepinephrine-only thinking. But does it actually help? Here's where we need to slow down, because the marketing and the actual FDA label don't fully agree. On the advantage side, post-hoc analysis across the trial program suggested benefit beyond core symptoms. On executive function, like planning and task initiation, and on emotional dysregulation, both areas the older dopamine norepinephrine-only drugs don't reliably touch. Onset is faster than atomoxetine, without the weeks of wait. And in adult trials, stopping the drug abruptly after long-term use produced withdrawal symptoms no different from placebo. A genuinely reassuring data point. Where it gets complicated is abuse potential. Pre-approval. The developer often describes centanafadine as low risk, leaning on the fact that it blocks reuptake, rather than forcing release the way amphetamine does. But the approved FDA label doesn't support a safer than stimulant story. Centanafadine carries 2 boxed warnings. One for abuse, misuse, and addiction potential, and one for suicidal ideation. It is explicitly labeled as a CNS stimulant. Human abuse potential studies showed real abuse potential. And at approval, the DEA hadn't yet assigned it a controlled substance schedule, meaning it's approved, but as of August 2026. When this video is produced, not yet legal to dispense in the US. That's centanafadine, the first triple reuptake inhibitor approved for ADHD, and the first real mechanistic departure the field has seen in decades. As DEA scheduling and real-world data come in over the next year, we'll be watching closely. And we'll do a follow-up once post-marketing data is available. And that's it for today's pharmacology video. If you enjoyed this video, please give it a thumbs up and subscribe to the channel for more pharmacology content.